Sabby. I'm a PGY1. I'm going to give a small talk, make it as fast as possible, in SCAPE. So sympathetic crashing acute pulmonary edema. And before I start, I just want to thank Dr. D'Souza, Dr. Kendall, Dr. Chu, and Dr. Turner for helping me prepare this presentation. All right, so we'll start off with a case. You are at the end of your overnight shift when the notification phone rings, and the call is for a 56-year-old male coming in with respiratory distress. His vitals that they give you over the phone, he's tachycardic to 109, blood pressure is 213 over 120. He's breathing at a rate of 33 and satting 92% on non-rebreather, and ETA is 5 minutes. So patient arrives, he's agitated, he's in clear respiratory distress, barely getting out 2-word sentences. You listen to his lungs and he has rales diffusely. So you call respiratory and then you put the sono on him, and this is what you see. So he has a pretty reduced ejection fraction. You can see the LV is not very contracting very well, and the mitral valve is not hitting the septum. So you look at his lungs and you see that there are B lines diffusely. And this patient, you're seeing fluid in the lungs. So you look at the IVC, expecting it to be plethoric, but in fact it's not plethoric and there's some respiratory variation. So today I want to talk about APE, but I want to focus on a specific subset of patients in APE, and that's going to be SCAPE. So what is SCAPE? SCAPE stands for sympathetic crashing acute pulmonary edema. It's also known as flash pulmonary edema or acute hypertensive pulmonary edema. I think it's important to conceptualize acute heart failure as like a spectrum of disease, where on one end you have patients who are mild decompensated CHF, and on the other end of the spectrum you have patients with this rapid progression of pulmonary edema with severe hypertension. So part of this talk is going to be distinguishing those two entities. So let's talk about pathophysiology. Why does this happen? The patient is exposed to some kind of stress. Something puts this patient over the edge. Maybe they exerted themselves a little more than they're used to, and their body has an exaggerated stress response. So they go into sympathetic overdrive with a massive release of catecholamines like epinephrine and norepinephrine, and they develop widespread peripheral vasoconstriction. So now their arterial and arteriolar system is clamped down, which translates to a very high afterload. The heart sees this very high afterload, and as a result, the left ventricular end diastolic pressure increases. This gets transmitted to the pulmonary system and causes pulmonary edema. So now there's all this fluid in the lungs, the heart rate goes up, diastolic filling time goes down, and the patient is systemically hypoperfused. This causes more stress, more sympathetic overdrive, more catecholamines, and this patient sort of spirals and presents the way that they do. So it's important to understand that this is not a disease of volume overload, but volume redistribution. This patient does not have acute pulmonary edema because they have too much fluid overall, but their fluid is just in the wrong place. And that's going to be important in addressing management as well. So clinical features and diagnosis of patient in SCAPE. Their dyspnea is going to progress very rapidly over minutes to hours. And on exam, they're going to come in restless, agitated. You'll hear rales all throughout their lungs. On the sono, you'll see B lines. And I know previously on the focus slide I had the heart, this patient had systolic dysfunction, but that doesn't always have to be the case. The patient can have this presentation with preserved EF. So if you do a sono and you see normal EF, don't let that sway you from making this diagnosis. And IVC is important to look at too when you want to assess volume status, because these patients very frequently are actually euvolemic or even volume down. So this diagnosis is clinical. You're going to utilize your history, exam, and your bedside sono. And again, this develops very rapidly. And I just want to kind of sort of, I have this slide to distinguish these two and sort of highlight the differences. So in acutely compensated CHF, this patient presents usually over a period of like days to weeks of increasing dyspnea, reduced exercise tolerance. and they are going to be fluid overloaded. So their management is going to focus on both preload, afterload reduction, but also diuresis. Patient in SCAPE is going to present in a different time course. They're going to have very rapid onset of symptoms, so like minutes to hours, and volume status, we said they're going to be either normal volume or even a little low. And their blood pressure is going to be very high as a result of that sympathetic surge that we discussed. So systolic blood pressure will be somewhere like between above 160 to 180, and very frequently in the 200s. And while management of this patient is also going to be preload and afterload reduction, primarily we're going to focus on afterload reduction, because that's really what's causing this presentation. The etiology is vascular. So that's what we're going to address in management. So management of this patient is going to be primarily with positive pressure ventilation and high dose nitroglycerin. That is the way that you manage a patient in hypertensive acute pulmonary edema. Diuresis, which we'll talk about a little bit, but diuresis is not indicated in the initial presentation of this patient. Like we said, they're not really fluid overloaded. In fact, they can be intravascularly depleted. So if you give them furosemide, theoretically, you could make things worse initially because you intravascularly deplete them further and you activate RAS and increase their sympathetic tone, and you can potentially make things worse. So quickly about positive pressure ventilation. It's been proven, or there's a lot of studies on positive pressure ventilation in APE, but basically decreases intubation rates with a number needed to treat of 8. So for every 8 patients that get positive pressure ventilation in APE, 1 patient is saved from being intubated. And that's because it decreases the work of breathing. It opens up collapsed alveoli, and alveoli that are filled with fluid. When you give these patients PEEP, it pushes fluid back into the intravascular space. And increased intrathoracic pressure decreases preload, and at high doses will also decrease afterload. Okay, nitroglycerin. So the way nitroglycerin works, it's converted to nitric oxide, which increases the levels of cyclic GMP and causes vasodilation. So the literature sort of varies on the exact dosing of a nitroglycerin, but the overall consensus is that in this subset of patients, high doses are most effective. And that's because at low doses of nitroglycerin, you only achieve venodilation, which is preload reduction. But in pathophysiology, we talked about this is more of an afterload problem, and you're not addressing that with low doses of nitroglycerin. So high doses of nitroglycerin achieve arterial dilation, and there's varying sort of doses in the literature, but like what I've read is that above 150 to 250 micrograms is when you achieve per minute is when you achieve arterial dilation and afterload reduction. Okay, so there's a few different ways nitroglycerin can be administered. Of course, we know sublingual and transdermal. Sometimes these patients get this en route by EMS, which is fine. But if the patient has a line, you really want to get IV nitroglycerin in this patient. And the way you can do this is either by putting them on a nitro drip or bolusing nitroglycerin. And there aren't really any RCTs on this, so there's no official recommendations and there's no really right or wrong way to do it, but I did want to go over just 2 studies that talked about infusion and bolusing nitroglycerin in this patient population. So this is a paper by Wilson, and it's a retrospective cohort study of 395 patients, and they looked at, or they separated patients into 3 groups. So there's a nitroglycerin bolus only group where patients received 2 milligrams IV every 3 to 5 minutes at the discretion of the EM provider in terms of how much they got. And then there was an infusion only regimen. Patients were started around 20 mics a minute and went up to 50 mics a minute, so pretty low dose. And then there was the 3rd group is patients that received a combination of bolus and infusion. So the outcomes of this study showed that patients who received high dose boluses had significantly shorter lengths of stay and lower ICU admission rates than those who didn't. Now, these findings may have been compounded by the fact that the institution required ICU admission in any patients that were still on an infusion. But one of the most important takeaways from this study is that all groups, regardless of the dosing regimen, had low incidences of hypotension reported, which is a feared complication of patients who receive nitroglycerin. So there's also this study by Levy. It's a feasibility and outcome analysis. So it's a non-randomized, single-arm, open-label trial, only 29 patients. But patients in the intervention group received high-dose nitroglycerin. So the dosing was the same as a previous study, 2 milligrams every 3 to 5 minutes, with a mean dose of 6.5 milligrams. And what they found is that patients who had received high-dose nitroglycerin had lower rates of intubation and ICU admission than those without. And out of the 29 patients, only 1 patient had symptomatic hypotension after the 2 milligram bolus, which resolved with a 500 cc bolus of fluids, and there was no other complications. So the level of evidence available for high-dose nitroglycerin is not very strong, and it's definitely not strong enough to make recommendations about the dosing, but it's enough for us to say that it's safe and that it's effective. Okay, so takeaways. Patients with acute hypertensive pulmonary edema are usually not fluid overloaded, but their fluid is just in the wrong place. And we should be able to distinguish this patient phenotype from that of acute decompensated heart failure. And we can do that by sort of figuring out the onset of symptoms, how fast it developed, and their volume status, and also their blood pressure is a lot higher in patients with SCAPE. And the mainstays of treatment are going to be positive pressure ventilation and high-dose nitroglycerin. And these are my references. That's it. Any questions? Go ahead, Skip.
A couple things. I thought that was really good. I like both things you said. They're my favorites, BiPAP and nitro to treat pulmonary edema. Also, please give them enough oxygen while you're setting it up. That's important. And people forget, but sublingual nitro, as you said, is the way to start, because it may take a while to get the IV and for the nurses to set it up. And when you're giving sublingual, each tablet is 0.4 milligrams, and it goes in really quick. So you're bolusing them fairly quick until you can get that IV set up.